were your real-time challenges?
It was an era when biology was not meant for boys. Biology was meant for girls who don't get married.
You have more than 5,000 plus citations. Your research really helped the obstetric world in the country and across.
If I'd probably not done that, not published that paper, maybe, I don't know, AMH might not have come as a test for ovarian reserves.
COVID came and lives changed.
I think one of the biggest case series was, 15 patients, pregnant women with COVID. But that was bad.
COVID-19 outbreak has obviously been very terrifying, especially for pregnant women.
And we showed that yes, there is evidence of mother-to-child transmission. Based on our work, the decision to vaccinate pregnant women was taken.
I would first want to begin with 3 decades back. Literally, I think it was in 2002 when you joined the NIRRCH, and it was the era where reproductive biology was not very well understood. And I am sure we are still miles away to know about the intricacies of this particular branch. But I really want to know, what pushed you forward to become a scientist and a researcher in this field of reproductive biology?
So thank you, Garima, for inviting me, and it's such a pleasure being here. And yes, if I transport myself back 2 decades ago.
Yeah, more than.
Yes, a little more than 2 decades for sure. Yes, it was a difficult decision in the sense that there were very few options. But I loved biology since my school days. And most people call me stupid because that was an era when biology was not meant for boys. Biology was meant for girls who don't get married. So I went against the wind, and I decided that I'll pursue biology. Most people call me stupid. What would you do with a biology degree? Because either you should do physics, chemistry, or computers. But I enjoyed it. I said, okay, let me just dwell about it. Walking ahead, I think I started enjoying it more that I read it, more that I enjoyed it. And that was the journey that began it, and that led me to do a PhD. I enjoyed teaching, I enjoyed doing research, and I think that was somewhat inbuilt in me. And I decided that, okay, let me dwell into both. I taught for 2 years, didn't enjoy much because it was probably too monotonous. And then I decided to do my PhD, and I landed up in Wadia Hospital for Children, where there was a project ongoing on starting to do prenatal diagnosis for Down syndrome.
Okay.
And that's where my journey began to reproductive medicine. Okay. That's where I got exposed to most obstetricians and gynecologists at that time, and they kind of became my role models. And that's where I felt that, no, I should do something, because the community which needs research and which is probably at that point of time was the least addressed community.
Yes.
So that's what all started with.
There was, even in the clinical front, that was the time when people were not very open to the field of reproductive medicine. And there were clinicians who were facing difficulties, and something coming from a research end which was not even thought of. What were your real-time challenges, considering it was something that was happening in India with limited resources around? It was something which was very new and something very unspoken, and the society was not ready to address it.
Yes, so definitely it began with a lot of challenges because 2 different things happened. One was absolutely socially, culturally, this is not something that was spoken about. I started doing genetics, which was again even the clinical community was not an accepted thing to do, because most people felt that, oh, it's genetics, you can't do much. And it was largely meant for pediatricians, and I was transgressing pediatrics to obs-gynae, and people were like, considering, oh, what would we do with all of this? But I think there was a set of people who really inspired me, pushed me into it in Wadia Hospital at that point of time, who said that, no, if we don't move ahead with technologies, we'll be ages behind. And I think our women need it.
Yeah.
And that's where it started. And the good part for me was across the road was that time called IRR, which is now rechristened as NIRRCH, had already set the legacy, because We had the first scientifically documented IVF baby through efforts of our director then and Dr. Indira Hinduja.
Yeah.
So I think the legacy in that region, the local area was set,
Yeah.
and that I think landed up moving things faster for me, because I think that whole area was bubbling with new ideas. The researchers, the clinicians, everybody being in the same vicinity wanted to do something more than what they could offer. And I think I was at the right place at the right time.
And I have also seen that a lot of times the researches which are done in the labs, they don't hit the clinics. But your work has always had a clinical impact for the patients. So again, going back to those early days, how difficult or how easy it was to convince the clinicians and the embryologists to join those hands and believe in the research studies which were coming up from India, from their own city?
Yes. It was, I wouldn't say difficult, but it was definitely challenging. And I come from a different world, where worrying about how a protein moves from left to right or how a gene goes from up to down, making clinical sense of that work was not imaginable for me, because we weren't trained with that kind of a thing. Because at that point of time, researchers wouldn't go to hospitals, clinicians wouldn't come to research labs. The crosstalk was very, very less. But I think there were some people who really, what we discussed, role models, were there. And one of them, in fact, so I remember very clearly, I think it was Dr. Vinita Salvi, who really changed my perspective to the whole thing. I was collecting endometrial biopsies for one of our projects, and she was our collaborator. We were trying to look at what are the genes required for receptivity. The ERA test, what we talk now, was something which we had imagined it then. Yeah. And she was like, okay, take it. And like as usual, typically clinicians were readily giving us samples and doing some things. One day she just calls me and tells me, Deepak, come here, tell me exactly why you're doing all of this. I said, oh, I'm doing this receptivity, proteins and all that. And she said, okay, so what will I do for my patients? So I said, oh, I can tell you the endometrium she's infertile, because there was no concept of ERA or receptivity then. We never thought genes could be used for receptivity. And I said, I can tell you that she's infertile because of lack of these proteins. And she started laughing hysterically. I was like wondering why. She said, what will I do with your protein test to tell me she's infertile? Because I know she's infertile. She's walked up to my clinic because she's infertile. You really need to change your perspective. You need to understand that research is not something that's happening in the lab. What you do there should translate to my patients. And the faster you do it is early. And I think that set the stage for me.
Wow.
That initial thought process that she instilled in me, that whatever that you do must benefit the people of this country. And I think that changed a lot of things. So now when I do research and when I want to begin a new project, the first thing you will see asking me often in our meetings is that, okay, imagine that if I have this test for you, would you use it for your patients?
Yeah.
You know that I do that, right? And now you understand why. Because I wouldn't want to invest my time and the public money to do something which is completely, out of the box, which probably is not going to see the light of the day. So I think that's where what in our terms we define as translational research came into existence.
Wow. And that's why for everyone viewing this, I always say this is the importance of having the role models and the mentors, because one person can really change your perspectives, and we have a living story over here. So, well, like an ERA, I believe you are a person who has always thought about things which have happened in the future, but you have thought it quite earlier. So there's a test which is now literally an over-the-counter test, an anti-Mullerian hormone or an AMH, which nowadays even the general population is doing it on their own to assess their ovarian reserve. The time when you were doing PhD, this role was not even established. We were not even correlating anti-Mullerian hormone to the ovarian potential, but you did your study on this particular subject. So I want to know, what were the challenges at that point of time picking up a topic which was not heard of? And how do you feel today when so much of research is happening around this topic, something that you had thought about 2 decades back?
Yes, so I'm sure you've done a lot of research on me now by now.
That's my work.
Yes, so that was something which honestly was completely out of the box thinking. It was my PhD, and we were looking at actually patients with ambiguous genitalias and disorders of sex differentiation is what we call. Because I was also working at a pediatric hospital, and we would see a lot of these babies. And at that point of time, about 5 years before that, the anti-Mullerian hormone was just discovered. It was also called as Mullerian inhibiting substance, MIS.
Yes.
And it was just discovered, the proteins about it were found out. And then we were wanting to use that as a marker to see that if this genetic gonad was a testis or an ovary. Obviously, we had to establish our norms there, and we were looking at whether that's coming from the gonad. So while we were doing this, incidentally, I picked up some sections which were of fetal ovaries, and we did started seeing some signals there, and that intrigued me a lot. That drove me to the curiosity that why am I seeing this in this, which was not anticipated. Obviously, the initial period of self-doubt and did I do the right thing, did I put the right experiments? And yes, it was fairly reproducible. So we started looking more into the ovary. The testis part took a little away. And we established, okay, it's there in the ovaries, right from fetal ovaries to adult ovaries. We had access to monkey ovaries that time. So we looked at the monkey ovaries and we said, oh, wow, it's there. And when I presented this to most clinical meetings, again, they said, this is stupid. This is a testicular hormone.
And how did you take it?
How did you take it? Why did you even look at it? And there was a lot of criticism. Obviously, it did set me back. I said, oh my God, I put so much of effort. I thought I made a eureka discovery. And as a student, you're always looking forward to the positive comments from your peers.
Yeah.
And the seniors would really criticize. But I think that was really, I feel very proud about that work. It was a very simple work. We tried to publish that paper, which again, it was difficult because internationally people did not agree to it. But around that time, one of the labs in the US, if I correctly remember, did publish that the mouse ovaries has anti-Mullerian hormone. And then we quickly published, we sent our work and said, oh, we also see it in humans and monkeys. And these are the 3 papers which set this idea that, okay, it's produced by the ovaries, nothing more than that. By the time some great soul had shown that AMH is there in the serum of male babies. So then somebody picked up that, okay, they looked at our papers, and if it's produced by the ovaries, it is there in the serum or not.
Yeah.
And then they found it in the serum. And then because we had shown that it is correlating with the numbers of follicles in the ovary, and that as the woman is aging, and if we take menopausal ovaries, there is no AMH. Somebody made that correlation from our work and started thinking that, okay, if it's there in the serum, does it match with age? And then the story comes that, oh, it declines with age like it's declining in the follicles. And therefore, it became a marker. And I feel so proud that if I'd probably not done that, not published that paper, maybe, I don't know, AMH might not have come as a test for ovarian reserve. So each time I see a report of AMH, I feel very proud. I feel very grateful to the superpowers around that made me do that. And I feel I've contributed maybe a little. But yes, I feel very good about it. So it was one, curiosity, persistence, and probably a lot of good luck.
Wow. I mean, as a clinician, it sounds just one blood test, but never did I think about it that what kind of research led to this such an important test, which is now predicting our outcomes. So, I mean, really tough journey, but you have more than 5,000 plus citations as well, and in so many indexed journals. In your early days, how did you develop the credibility and collaborate with the global research leaders so that, and how did you have that vision that I want to put India on the map for fertility research?
Again, mentors. I think when I joined the institute, and at that point of time, it was most of the times Me Too work kind of happening in India, that somebody else has done it. And we say, oh, it's there in Indian patients or it's there in Indian women. But our director at that point of time said that this is not enough. You have to be visible globally. And the visibility index is what he gave us the impetus for. He would send us abroad. He would allow us to present a lot of our work in meetings, conferences, as posters, and pushed us to publish at those international journals. He said, if you submit it, fair enough. It comes back, fair enough. But if you don't attempt it, it'll never happen. So I think give us a lot of courage and the visibility to, think big and think larger than life. And that probably made a lot of difference. And that's where I think the whole journey started. And then when I went abroad, I realized that they're as good humans as us. They just think like us. We should not be considering them as superior to us or we are inferior to them. We are at par. It's just that our facilities and our requirements are very different. And that actually, by that point of time, I also get this idea that, yes, we must do fundamental research, which was always my forte, but research not to compete with the globe, but rather research for our people. And that reminds me of a statement by Vikram Sarabhai, who said that we are not here to compete with the developed nations, but we are convinced that we will continue doing fundamental research for the benefit of our people. And we do research of what our people need. And I think these two things really help me to grow and come to where I am.
Wow. So you also talked about the facilities. Now, the ecosystem in our country has had its own hurdles when it comes to the research field. I mean, the funding, the availability of space, and sometimes the bureaucratic hurdles as well. Could you also share some of these struggles that you faced or the younger generation is facing today? And what were your strategies to calmly and peacefully, say, okay, these are there, but I'll continue with my fundamental work. So that's what the youngsters, the patience and the calmness in the work they need.
Yes, so I think struggles are there everywhere. It's not that you didn't have to struggle to make it to what you are. And I think struggles are part of evolution, survival of the fittest.
Yeah.
And if we don't struggle, we would just not grow. And my favorite statement, I forget the author who made it, but he said that even to remain status quo, you need to evolve. And that's something that gets me going, that, okay, there are difficulties, but that's my goal. This is what my people want. This is what my doctors want. This is what my women in the country need. I must work hard enough to get it to them. Nothing can stop me. So curiosity, passion, and of course, the right ecosystem, as rightly mentioned, that sometimes we keep blaming others that, oh, the ecosystem is not right, but we forget that we are also a part of the ecosystem. The ecosystem is also us.
Yeah.
The fact that we are sitting today here is because we are the part of the same ecosystem. You don't consider me as an outsider. And this ecosystem has changed over years. I don't think when you were probably as a student, you wouldn't see a researcher walking up to a clinical meeting and talking. And now you see that there are many of us who do come and we work together. And I think that's where the change comes, that I also have to have the willingness of talking to you of what you would want to hear, the way you would like to listen. If I come and give a very fundamental talk of our that Hoxton twist to crosstalk, you would enjoy it for a minute, but then the next thing is that, okay, how it's changing my patients. I can't give that kind of a talk to you. Yeah. But at the same time, I can't also talk to the researchers about how clinically the whole thing became relevant. So all of us have to take steps. You took 2 steps ahead that, okay, let's understand what the research community is doing. I also had to take 2 steps ahead and understand what you guys need. And I think that's where the whole ecosystem got created. So yes, initially it was difficult and it was challenging in terms of facilities, in terms of funding. Everything is very expensive in research. But yes, the government does have a positive attitude towards researchers. And I think it's changed a lot since the time of COVID, where the government saw that the research community is strong in the country. Okay, then I'll leave it for the next set of it. But yes, the ecosystem is there. The things are in place. It's just how we make about it. How we make the best use of our ecosystem rather than being parasitism. I believe in symbiosis.
Yeah, very true. So now that you have touched the topic, I have always seen you as somebody very flexible. We have differential mindsets. We have differential attitudes. No offense, but yeah, some people are rigid that if I'm supposed to work in this particular field, I will stick my study only to this. COVID came and lives changed. We literally, clinicians had no idea. IVF so completely got shut because we didn't know, it was not an emergency, and we didn't know how things are going forward. We didn't know what to do with our obstetric patients. But then came humongous amount of research that you did at that point of time. I mean, one, hats off to your flexibility, credibility. But I really want to know, and I would want our viewers also to know the tough journey of the COVID era. And because your research really helped the obstetric world in the country and across. So if you could share some insights from that era.
I think that's an era which I would want to visit and at the same time not want to visit. The struggles which each one of us has gone through with the idea that should I step out of the house? I have my aged parents sitting at home. Should I go to the institute and work? Or with the whole idea that I'll get probably the virus home and my parents we need to be hospitalized was itself on one point killing. And at the same time, I also felt the need that I need to contribute to the country. And I think that's what the entire research community did. That whole desire that, okay, we are a part of one nation and we have to contribute to the country in the best ways that we can. Each one of us decided that let's look at our fortes and let's start seeing how we can help it. I remember this was, I think, the last travel. I was for a meeting, I think in Bhubaneswar, or I think one of the ISAR that happened around
the Hyderabad.
The Hyderabad ISAR. I was coming back, and by that time we were still not
10 days in the lockdown. 10
days in the lockdown. I think by the time the heat was feeling around the world, and we were starting to feel that something, when the virus might even come to India, we might have issues. And on the flight back, I was just sitting, and the thought just struck me that the first thing, I mean, obviously our first thing is to save lives, and the government would obviously look at diagnostics first. Treatments first, what would the protocols for saving. But once that's settled, the obvious question would be, what will happen to our pregnant women? Which is a significant part of the world, part of the country. Are they going to get infected? What's going to be the infection looking like? Will they transmit the virus from mother to the child? And because IVF community is very close to me, and obviously there were already phone calls saying that, okay, what do you think is going to happen to the patients who are taking IVF? Should we continue the cycle? Should we stop them? What of those we have started? So a lot of questions had started coming, and we thought that these will be not the emergency questions, as you rightly said. It's not something which is so emergency, but at the same time, the need was felt that these questions would come to us from the government. And I think that preparedness was something that had come in us by that point of time. So with my colleague, Dr. Rahul Gajbhie, where we would travel together from our homes because some of us were on emergency duty through ICMR, and we had to report to the institute daily. And on the way, we discussed and we said, okay, Rahul, I think let's utilize this time to the best and let's do something for the pregnant women. The obvious question would be, what's going to happen to them? And should we vaccinate them, not vaccinate them? But the vaccine had still not come. But the hope was that we'll have some medicine. Can we give it to them? So he started this Preg-COVID registry, where we started collecting data of pregnant women, reporting of COVID across the state. By that time, we had already did the first systematic review of the reported cases in the world, and we did report that pregnant women do have adverse outcomes.
Yes.
Obviously, coming from India, not taken seriously by anyone. They said, oh, this is not so important. And even at that point of time, we were presenting this work, we were publishing this work, but it was not taken very seriously because the priorities were different. But I think that didn't put us down. We said, as soon as this part is over, this is going to be the next obvious step. So I think looking at the future was something that we had already inculcated as a part of our training. And we started, on one hand, we started collecting data. We started looking at what people are publishing, case reports, case series. I think one of the biggest case series was, 15 patients, pregnant women with COVID. And then we realized that there were different data coming from different parts of the world. I was talking to the gynecologists who were, obstetricians who were delivering babies, that please let us know what's happening. And if it's one case, it does matter to us. We were also struggling how to collect this data because this was not something which we had done before. But I think slowly the whole thing built. And by that time, because my lab had expertise in looking at placenta, we also thought that, okay, because the virus transmits from mother to child, let's look at the placenta and see if the virus receptors are there or not there. My idea was simple, that the receptors are not there, which I was very hopeful for.
Yeah.
And the virus would not transmit to the baby, and our women would be safe, our mothers would be safe, the babies would be safe. But that was bad, because the first time that my student showed me the data and we realized that the virus receptors, its replication machinery, everything that the virus requires to survive in the lung was already there in the placenta. And that was kind of difficult. We had a lot of challenges again there, because we were reporting the presence of these receptors in the human placenta. Another group from NIH, the US, said the other way. And there was a lot of conflicts. They criticized us. We criticized them back, because I think by that time we had the power to say, okay, you can't talk shit.
Yeah.
This is real. And by that time we had the first case of mother-to-child transmission coming to our reporting clinic.
Okay.
And we showed that, yes, there is evidence of mother-to-child transmission. We did show the baby had developed a hydrops and it did take a time, but I think that by that point of time, people started taking us seriously. And things went on. We published a lot of pregnancy outcomes in pregnant women, but nothing really was, kind of everything was great. Okay, yes, you're publishing, you're doing good, you're contributing to science. Nothing really clinically game-changing. Like, it's okay. This much was our job. Till one fine morning, we get a call from DG ICMR. Rahul gets a call, and he says that, Dr. Rahul, please send us all your pregnant women data right now to us. We need to take a decision whether to vaccinate pregnant women or not. Because by the time the world was, pregnant women should not be vaccinated. Because we really don't know what happens to them. And obviously you can't run clinical trials on them. We did show that as compared to the first wave, the second wave had higher mortality rates, way higher than even the non-pregnant population. We did show that the outcomes were more adverse. There was higher incidence of fetal deaths in those. And that data, DGICMR presented to ministry, and based on our work, the decision to vaccinate pregnant women was taken. And I think that moment, like AMH, this is the second lifetime difference that I see, that some little contributions which we began with.
But I have to applaud you on behalf of the whole society and the country's population for that.
Thank you.
I think your preparedness and your dedication to give it back to the society has led to some of the biggest innovations, and we are proud Indians to have researchers and scientists like you. But this brings me to another question. In your opinion, what is the key strength of our country when it comes to the reproductive biology research, which the world still underestimates?
So, the key strength, I feel, is one, we have the infrastructure.
Yeah.
We have the right kind of people who really want to work. We have the right kind of clinicians who really want to do, and the numbers that we have. I think we probably in IVF, I'm sure we do the largest numbers of cycles in the world. And I think we have a lot of data.
Yeah.
It's time that we come together, integrate all of it. I understand that as busy clinicians, you wouldn't have time to analyze it. The problem, I think, starts with is that we all want to do each other's roles. And I think that's where we should stop. That we should leverage on each other's strengths, which the ecosystem is there. It's time that we just get together, talk to each other, understand each other's languages, and move ahead. I think if we just get all of this together, we'll be the best in the world.
Yeah, very well said. And so if today somebody thinks of entering the research world and wants to pursue the career in the reproductive biology, what would be those 3 steps that you would recommend or you would advise somebody as a beginner to, 1, begin the research work, number 2, have a practicality of the research work, and number 3, a collaborative efforts with the clinicians and the embryologists? So what will be your key steps and measures that you will?
So first is definitely passion. You need to be passionate about what you are doing. This is not something which you choose because there is a lot of scope.
Yeah.
In India, often the whole premise of choosing a career is in scope zyada hai, isme kam hai. I don't think that's something which we need to think. We need to rather look at it that if you're passionate about it, there is scope everywhere. So 1, have passion, have curiosity, persistence, and collaborate. The last statement which you made is very crucial. Collaboration is the key to success. It was not a one-man show here. It began with my clinical colleagues willing to help me out.
Yeah.
It was my statistical colleagues who came up to me. We all speak together, we discuss. In fact, now some of the research that we do is also with engineers. We are developing models and devices. We do with computer scientists. We are doing a lot of molecular modeling. We are doing a lot of population modeling to seek answers. And AI is one of them, which you see as an outcome of crosstalk between engineers and clinicians. So I think it's passion, curiosity, collaboration.
And this brings me to something else, role of AI in the field of research.
Oh, I think I have very long talks actually on...
No, I want something very practical is to... people are afraid also of AI, that AI is going to replace them. Mm-hmm. Whereas I always feel that you are going to be the master for the AI. You are going... So in terms of the research work, where does AI till now, where is India standing in the role of AI in research field, and where do you see us 10 years down the line as a global market in the field of fertility research?
So definitely AI, I mean, within the scope of Indian research community, yes, as of course anything that's new, there is a set of people who are going to be scared of it, skeptical of it, and there'll be other set of people who are extremely passionate. The community always is divided into two. Even the IVF field, we know some people readily adopt to new technologies and some people just resist and wait till they see the results. And I think you need both for an ecosystem. So I don't get worried when there are people who say that, are scared of AI or rather, I would say are a little skeptical of AI. But I think that's the way to go. We have transformed ourselves from using a cord-bound telephone to digital era. And yes, we have lost some skills. We have lost the ability to memorize numbers, but we have got different abilities. And I think these are part of evolution. And I see AI also as a part of our evolution to the next. Talking specifically about reproductive medicine, I'm sure you're more aware than me about how AI tools are coming for selection of embryos and selections. But things are transforming in a big way and in much different way. Just to give an example, there was a paper published, I think in July, where they call something as a virtual lab, where there is a principal investigator, which we call ourselves scientists as, and there is also a virtual principal investigator. There's a virtual immunologist, there's a virtual hematologist, there's a virtual molecular biologist, and these people were asked to design a drug against SARS-CoV-2, and the AI actually designed a new drug which is working for not just the existing strains but the forthcoming strains as well. So that's the way the world is going, and I don't see reproductive medicine any far. We are trying to embrace AI and we are saying that, okay, can we use all the clinical data available and help you to predict whether this woman is going to be a responder or a non-responder? What is her chance of success? What's his chance of giving sperm? And in fact, one of our papers which we published earlier on, where we did show that if you do a genetic test, and if the genetic test comes positive, you should be able to predict very accurately what is his chance of sperm retrieval and a live birth. So that's the power of AI. I don't think it's going to replace you, but it's definitely going to replace the way you're thinking, the way you're approaching it. What is more even currently more the test of probability and guesswork. Your ability to predict that probability is going to be much higher. So it's now no more a mental game. The mental game is being done by someone else. It's now, okay, here's a number, what next? How can you get better for the practice? I think that's how AI is going. And it's time that we all, again, collaborate, where we look for a lot of clinical data, more the data, cleaner the data, better the predictions. So that's a field where we all can join hands immediately to begin with.
And I think if we all take it as an evolution tool, it will take us way forward rather than taking it as our competitor.
Yes.
So, well, that also brings me to another breakthrough paper that you have recently come with. That's one thing which I wanted to put a highlight because it's the incredible amount of research that you have been doing. And as clinicians, for us, literally our hearts aching to give pregnancy to that one woman. Every research that you come across helps us giving one probable tool of giving a childbirth to the couple that we see. So the Hawks A10 paper. In very brief, somebody who can very well understand in the community that how will it help the community tomorrow in improving our clinical management?
Definitely, and this is one question I've been posed upon since the publication of that paper. The paper is very close to my heart for several reasons. One, that was a question which I had imagined when I started my lab. When we started looking at embryo implantation, the question I had was that how does the embryo breach the epithelium? One, we for sure knew from IVF experience that even if we put the best quality embryos, genetically normal embryos, so many refuse to implant. And we thought that there should be something in the endometrium which could decide what should allow it to implant. And I realized that it's not receptivity, which is a rate limiting factor, but the ability of the embryo to breach the epithelium and get inside is a rate limiting factor, because most of the time it's not even beta HCG positivity, and if it is there, it just comes as a blip and goes off. So we realized that the problem is lying that the embryo is unable to breach. Then I looked up the literature and asked that, okay, if you have to devise management strategies for that, we need to understand what's happening in the womb. And then we realized that we didn't even know how the breaching of the epithelium happens for the embryo to invade. There were like talks where people said, okay, the epithelial cells die, or the epithelial cells get eaten up by the trophoblast cells. And we said that, okay, if they die, if they get eaten up by the trophoblast cells, it's going to create a lot of inflammation, which is obviously not very desirable for pregnancy to occur. So we thought of alternate mechanisms, and I think we had imagined something which we called as epithelial to mesenchymal transitions. So remember, epithelial cells are pretty tight. You know, viruses don't get into anything that's epithelial. Now, if the whole embryo has to get through it, that has to like open the door. So if you imagine epithelial wall as a wall of a fortress, if one has to enter in, some door has to open. And then using mouse models, hamsters, monkeys, and even in vitro human cell lines, we could show that this entire opening requires this transition of epithelial cells becoming mesenchymal. So we now imagine that, okay, there's a wall which has to be breached, the embryo knocks there, something's happened in there, and the cells, epithelial cells flatten up, open up the door, slide off, the embryo enters in and repairs back. And then we devised, obviously as researchers, curiosity drives us more, and then we wanted to understand what genetic factors or what molecular factors do that. And we work on this transcription factor called as HOXA10, and we realized that along with another master regulator, they work in exact opposition. And one takes over other, and the cells become mesenchymal. When HOXA10 goes down, twist2 takes up, and the cells become mesenchymal. They go out, and if you block twist2, HOXA10 takes over, and the cells get the epithelial fate. So it's a binary cell fate decision is what we describe as. Now, obviously, how is this going to help in a long run in clinical setting? At present, I don't claim that I have an immediate solution for you. But now that we understand these genetic networks, we know what players are driving this epithelial to mesenchymal transition. My imagination is that now we can identify drugs which will induce EMT. We don't know them yet. But now that we know this process is happening, we can target it. So for example, in cancers, epithelial to mesenchymal transition is something which drives metastasis. So there are enough EMT inhibitors. So in terms of contraceptives, it's the first thing we want to try. That can I use this EMT inhibitors as an emergency contraceptive or a local uterine contraceptive instead of a hormonal contraceptive, which we know has a lot of side effects. So that's going to be a low-hanging fruit for us. But in the long term, for the IVF community, the bigger challenge is now identify the drugs which are going to target these genes. And if I can induce locally the EMT at the site where the embryo is implanting, we should be able to improve IVF success rates. That's a long story. It's probably not something which you'll be expecting to see next year or the year after, but that's what my hope is.
Yeah, it's going to be another AMH in the revolution.
Yes, definitely. So just getting back to AMH and all of our stories, except for COVID, which was probably the shortest in translation, most things from the lab to the clinic is at least a 2-decade journey. Nobel laureates even claim it to be a 4-decade journey. Most Nobel laureates which get the Nobel Prize now have done those research, if you realize, 40 years ago. So it's a process. It's a time-taking process, because it won't be just me. Now that I've claimed it, there'll be at least different labs trying to verify it. There'll be people who will counter it and say, no, I don't think what you said was right. And then once we come to a consensus and we start showing very explicitly that yes, this process is targetable. This process, 1, definitely happens. 2, it's targetable. If I target the other way around, I can inhibit implantation. If I target the forward way, I can activate implantation. We would get these drugs. So yes, it's going to be time. Hopefully, when before my retirement, I should be able to give you some hope.
So with that decades of lab to clinical outset of any result, with your experience of more than 2 decades, where do you think India would be a decade later? Would we be one of the leaders in fertility innovation? Or we will still be trying to catch up with our counterparts? I know it's not about competition, but with so much of work that's happening, there's a ray of hope. And that's what I want to bring our audience to know and address to.
I think the fertility community, in fact, is the most forthcoming community to new innovations. I understand the reason that because you have very little, there's very little that you can do for your patients. You're always seeking for newer hopes for these patients, and the adaptability is very high. In terms of becoming leaders, I definitely see that, because now when we see the global market, I'm sure years ago, within research as well as I know within the clinics, the medicines would first get launched in the West and then come to India. Today, most companies want to launch their medicines in India parallelly to it. So I think we are there. We are getting to the leadership, because, as I said, the strength is the numbers. The best clinical trials can happen in the country. We have the infrastructure, we have the people, we have our patients, and we have the know-how. So I think we will be the global leaders in driving the fertility, both treatment and research, because the ecosystem is ready.
Thank you so much. I mean, your journey has truly been incredible. And I'm sure our viewers are going to take some of the very inspiring and motivating messages from the journey, from the views, from the opinion and the experience of Dr. Modi. Thank you very much on behalf of ISAR once again. And for all our viewers, stay tuned to hear some more powerful voices from the leaders who shape the field of reproductive medicine. Thank you. Have a great evening.
Thank you.
I was born into a gynec family. My dad was a gynec. So I was tuned from childhood that I have to become a doctor.
So at that point in time, people had a lot of stigma against IVF. There was nobody who had done it before. And in India, the cultures are different.
Even my seniors, my senior lecturers, registrars in KM, Jatin, this has no future whatsoever. This is a hopeless technology. Nobody gets pregnant.
But you made India on the mark for all the states to come into IVF.
Yeah, so we had the first IVF pregnancy of Kerala, first of UP, first ICSI of UP. All this were done when I was visiting.